Hello and welcome to this webinar about the Electronic Health Record Incentive Program. I am Debbie Robin, Senior Director for Quality at the AGA, and I will be your moderator. We are very fortunate to have with us today two experts on the regulatory definition of meaningful use and the Electronic Health Record Incentive Program. First, we will hear from Dr. Joel Brill, who will provide an overview. I apologize for the feedback. First, we'll hear from Dr. Joel Brill, who will provide an overview of the Electronic Health Record Incentive Program and the law that created it. Next, Dr. Lawrence Kaczynski will talk about the specific meaningful use and clinical quality measures that must be met to qualify for the monetary incentives of the program. And finally, our speakers will address questions from the audience. Just a few housekeeping items before we begin. If you would like to submit a question during the presentation, please type it into the question box on your screen. Questions will be answered by our speakers following the presentation. This session is being recorded and will be archived on the AGA website within a week at www.gastro.org. Now I'll hand the floor over to Dr. Brill to begin. Thank you.
Thank you very much, Debbie, and welcome everybody. This has been a very exciting time in terms of electronic health record systems. The most recent past few days have been filled with a lot of information, and over the next hour's time, we hope to bring you some stuff that will be of value to everybody. Can we go to the next slide, please? Disclosures, as mentioned here, I am the Chief Medical Officer for the AGA's registry, as well as I have a voting position on the registry's Executive Management Board. I do not have any relationships with any health IT companies. Dr. Kaczynski is a member of the HIMSS Patient Safety and Quality Outcomes Committee, and he is a personal user of NextGen. Next slide, please. During the next hour, we will review the updates to the Electronic Health Record Incentive Program, including a definition of meaningful use, what's a certified EHR, which is very important, especially with developments earlier this week. We'll discuss the initial standards and implementation specifications for EHR technology, the clinical quality measures that are required, the monetary impact, and what this means for the practice of gastroenterology and the endoscopy center. Next slide, please. Next slide, the Health IT Information and the Economic and Clinical Health Act. Next, please. So this will not be a test, but for those of you who want to know how this all came to be, the American Recovery and Reinvestment Act of 2009 included the Health Information Technology for Economic and Clinical Health Act, or HITECH, and it formally established the Office of the National Coordinator for Health Information Technology, known as ONC. HITECH provided funding to support regional and state initiatives to promote the adoption of electronic health records. There are, depending on who you speak to, north of $17 billion to almost $20 billion in total Medicare and Medicaid incentive funds for eligible hospitals and providers who adopt EHR technology by 2015. And the Act directs the ONC to issue regulations. Next slide, please. The national coordination process, everything ultimately reports to the Secretary of Health and Human Services, currently Secretary Sebelius, and that at the bottom of this slide you can see that there is both a Health IT Policy Committee, a Health IT Standards Committee. The Standards Committee receives input from the National Institute of Standards and Technology. Both of those committees report back up to the National Coordinator, who receives recommendations and decides whether to endorse rules, and the National Coordinator reports to the Secretary of HHS. In addition, CMS drafts proposed rules, accepts public comments, and administers payments. Next slide. There were 2 regulations published this summer. The CMS rule established the EHR incentive program. The ONC rule established the initial set of standards, implementation specifications, and certification criteria for EHR technology. Next slide, please. The CMS final rule addressed the definition of meaningful use, the clinical quality measures, who is an eligible professional, the incentive programs under Medicare fee-for-service, Medicare Advantage, Medicaid, and the regulatory impact. Next slide. The ONC rule set the initial standards and certification criteria, coordinated the standards required of EHR systems with the meaningful use requirements, and clarified that the use of certified EHR technology is a core requirement of the incentive programs. Next slide, please. The EHR certification programs, in the rule establishes temporary and permanent certification programs for the purposes of testing and certifying EHRs. The temporary certification program established processes for organizations to be authorized to test and certify EHR technology, with the final rule for the permanent certification program expected to be published this fall. This week, in fact, the government released the names of the first 2 organizations, the Drummond Group and CCHIT, which will be able to now review EHR technology, and we expect to see ONC certified EHR technology by the 4th quarter of this year. Those are not the only 2 entities. We expect that there will be other entities that may be approved in the days and weeks to come. It is also key to recognize that just because something was CCHIT certified prior to July of this year does not automatically mean that it has been certified by HHS. Any system has to again go through certification by one of the government's approved certifying organizations. Next slide. So anyhow, this is not a picture of Tony Soprano. This is a picture of David Blumenthal, the national coordinator, who is making you an offer you can't refuse. Quote, the federal government is making a one-time offer. We'll put money on the table to help you now, but we're not going to put money on the table later, end quote. Dr. Blumenthal, next slide, is quite correct on this issue. There is a window of opportunity, and if we don't take advantage of this window, there will not be any second chances after 2015. So here is the vision and progression of meaningful use. The vision is to enable significant and measurable improvements in population health through a transformed healthcare delivery system. The goals are to improve quality, safety, and efficacy, improve care coordination, engage patients and their families, improve population and public health, reduce disparities while ensuring precautions for privacy and security. So in 2011, the goal of Stage 1 is to capture and to share data. This is really all about building infrastructure and increasing the volume of transactions. By 2013, or Stage 2, the goal is to see advanced care processes and decision support. This involves registry reporting, electronic ordering, and home monitoring. It substantially steps up the exchange process as we start to aggregate and apply data. And by 2015, or Stage 3, the long-term goal, obviously, is a healthcare system and a health information technology system that improves outcomes through access to comprehensive data, interoperability of medical devices, and reporting on experience of care. The goal, of course, is clinical management and performance improvement. Next slide. So meaningful use is described in the Act as, quote, the use of EHR technology in a meaningful manner, end quote. For physician incentives, this includes the use of electronic prescribing. Meaningful use involves the electronic exchange of health information to improve the quality of care, such as promoting coordination of care, and includes reporting on clinical quality measures. And this will become more stringent over time. Next slide, please. Now, many have asked, what is an eligible professional? We're looking here solely at those who are non-hospital based, and it is important to note that a allopathic or osteopathic physician or a dentist is eligible under Medicare, whether fee-for-service or Medicare Advantage or Medicaid. Podiatrists, optometrists, and chiropractors are only eligible under Medicare. Nurse practitioners, physician assistants, and certified nurse midwives are only eligible under Medicaid, and as we'll talk about in a moment, under certain restricted conditions. If an eligible professional, such as a physician, is eligible for both Medicare and Medicaid, you can choose to accept the Medicare or the Medicaid incentive, but not both. And you do have the opportunity to change your election once during the life of the incentive program after making an initial election. Next slide, please. So, gastroenterology practices need to consider some high-level questions. Which incentive program do you want to participate in, Medicare or Medicaid? You are not eligible for the Medicare incentive program if you provide greater than 90% of your care in an inpatient or an emergency room setting. So if you are a hospitalist gastroenterologist and you never see patients outside of the hospital, you may not be eligible. You also need to look at the e-prescribing incentive program and note that under Medicare's incentive program, an eligible provider cannot get a payment under both the e-prescribing incentive program and the EHR incentive program for the same year, but you can receive payments from both. Could you go back a slide, please? But you can receive payments from both the e-prescribing incentive and the Medicaid incentive program for the same year. Please go forward. Next slide. PAs and nurse practitioners are eligible only under Medicaid. They must not be hospital-based. They must meet one of the following criteria. They must have a minimum of 30% Medicaid patient volume or practice predominantly in a federally qualified health center or rural health center and have a minimum 30% patient volume attributable to needy individuals. So the average mid-level working in a urban or suburban office may or may not be eligible under the Medicaid incentive program. Next slide. What else should we consider? Well, Medicare payments are calculated on an individual practitioner basis. And that's a key thing. So if you're part of a group, each eligible professional may qualify for an incentive payment provided that each eligible professional successfully demonstrates meaningful use. Again, each eligible professional is only eligible for one incentive payment each year, regardless of how many practice locations you provide services at. Physicians must demonstrate meaningful use in more than 50% of patient encounters to be eligible to receive the incentive payment. And so this means that we base all meaningful use measures only on locations where certified EHR technology was available. It's a very key thing. So it means, was the technology available in your office, in your hospital, or your ASC? Let's go forward to the next slide, please. So, what does this 50% of patient encounters must be in an eligible settings rule mean? Let's say that you practice in two offices. You spend 30% of your time in Office A, which has got a certified EHR, 20% of the time in Office B with a certified EHR, 10% of the time in a hospital without a certified EHR, and 40% of the time in the ASC. Remember, an ASC is not a setting for certified EHRs. Here, the physician spends 50% of his or her time in settings with a certified EHR. Those are offices A and B, so the physician is eligible. However, let's take now the second scenario. The doctor practices 30% of the time in an office with a certified EHR and 10% of the time in the hospital with a certified EHR, but spends the bulk, 60% of his or her time in an ASC without a certified EHR. Under Medicare's rules, you are not eligible for the incentive payment. So it's very critical to look at, especially for gastroenterologists, how much time do we spend in the ASC setting in order to be able to calculate the eligibility payments. Next slide, please. So the rules for the incentive path, the definition of a payment year is any calendar year beginning with 2011. 2014 is the last year an eligible professional can qualify for any level of incentive payment. Medicare will stop making incentive payments altogether in 2017. But even more important, if an eligible professional does not successfully demonstrate meaningful use of certified EHR technology, your Medicare fee schedule payments for covered professional services, that's all services, not just office visits or endoscopies, will be adjusted downward beginning in 2015. AGA feels that there are two scenarios that practices need to be concerned about, especially if you are a physician considering retirement in your practice in the next couple of years' time. You may be saying to yourself, why would I want to get an EMR now? But recognize that what you do may also have an impact on those who will come into the practice after you. There's a lot of money at stake, and just ignoring it may not be in the practices or the new people who join your practice in the future's best interest. Next slide. So here's the incentive payments again. If you start and get up and running in 2011, or you're up and running in 2012, you will receive by the end of 2016 a total of $44,000 in incentive payments. If you don't get started until 2013, the payments drop to $39,000. If you don't get started until 2014, the total maximum payment, and again, that's not a guarantee, it's a maximum payment, it's $24,000. And if you don't get started in 2015, you lose 1%, 2016, 2%, and in 2017 and beyond, you lose 3% of your overall Medicare payments. The maximum payment is based on up to 75% of Medicare-approved services or the above maximum. So, for example, if you got started this year, in 2011, you would be eligible for up to $18,000, but no more than $18,000. But if you didn't hit the 75% target, you would be eligible for less. Next slide. With this, I'm going to turn this over to Dr. Kaczynski, who's going to go into greater detail about certified EHR systems and the meaningful use criteria. Larry?
Thanks a lot, Joel. You did a wonderful job explaining a very difficult and complex set of legislative pieces there. Hopefully I can continue this through my piece of this webinar. Good morning or good afternoon, everybody, depending on where in the country we're speaking to you at. Next slide, please. My job is to try to get into a little bit more of the details of what meaningful use means to each and every one of you and what you have to do in order to be compliant. Remember these three bullets. Meaningful use, as Joel alluded to earlier, is composed of these three major pillars. You have to be using a certified EHR as defined in the final rule. You have to then be using that certified EHR in a meaningful manner that allows for health information exchange to patients, to other providers, and to government authorities for the presentation of quality metrics. What we exchange has to be in the form of structured data, and we'll talk about that in a little bit. And the final pillar, which will be the pillar that will become the strongest one going forward. The first two pillars are really basing the foundation, setting up the infrastructure, but quality measures reporting will define what happens in the future. Next slide. Okay, so what is a certified EHR? Well, it's one that conforms to the goals and the objectives that CMS and HHS have set out for us. They have split these up into a core group and a menu group. The caveat here is don't purchase an EMR that can't fulfill them. We're going to talk about them now. Next slide. As Joel alluded to earlier, this week, the ONC released the names of the first two entities that will be certified or will be qualified to certify EMRs. One is CCHAT, which we're all very familiar with, the Certification Commission for Health Information Technology, and the Drummond Group. But again, previous certifications do not mean that you're going to be carried forward. A fresh set of certification will be necessary. Next slide, please. Now, as I said before, there are core measures and there's a set of measures that we call the menu set. The core measures, there are 15 of them. They are mandatory. Every one of them has to be met in order for your EHR to be certified. And they are driven by the goals. So if you remember from one of Joel's earlier slides, goal number one is to improve quality, safety, efficiency, and reduce healthcare disparities. And if you then look at these core measures, they apply to this goal. CPOE, computerized physician order entry for medication orders. In stage one of meaningful use, this will only be for medication orders, but this will be for all orders in later stages. You will need to have drug-drug allergy interaction implementation. You will need to generate and transmit prescriptions electronically. Demographics will need to be recorded digitally, preferred language, gender, race, ethnicity, date of birth. We all do most of this right now in our practice management system. But something addition, we will need to maintain up-to-date problem lists of current and active diagnoses. Next slide. Again, under the same goal number one, you will need to maintain an active medication list, an active medication allergy list, record and chart the changes in vital signs for patients, record smoking status in patients who are over 12 years of age, and then something that is a prelude to much more to come in the future, but in stage one, implement one clinical decision support rule relevant to your specialty or a high priority issue, along with the ability to track compliance with that rule. And finally, report ambulatory clinical quality measures to CMS or to your states, depending on what your local laws are. Next slide. Goal two is one that brings in your patients and families into the healthcare process. And these core measures are as follows. You need to be able to provide your patients with an electronic copy of their health information, which will include the following bullets: the diagnostic test results, problem list, medication list, allergies, upon their request, and there's a 4-day time limit upon releasing these. You will need to provide clinical summaries for patients for each office visit. You'll need to have the capability to exchange key information, problem lists, medication lists, allergies, and diagnostic test results to each other, to other providers of care. And as we will discuss later, these are not just by means of fax to each other. They're going to need to be in the form of structured data. And finally, as we all have to do, you need to protect your electronic health record and maintain the appropriate technical capabilities. Next slide. Okay, now that's the core group. The core group are all required. In the menu set, there are 10 items in the menu set, and you need to pick, you can drop 5 of them out of the list. So again, these refer to goal number 1, implement drug formulary testing, incorporate clinical lab results into your EHR as structured data, generate lists of patients by specific conditions. Again, as Joel alluded to, registries are going to be very important going forward, so we need to first be able to generate those lists of patients by specific conditions in order to provide quality improvement, reduction of disparities, research, or outreach. And then finally, send reminders to patients for their preference for preventative or follow-up care. Next slide. Again, engaging patients and families under Goal 2, providing patients with timely electronic access to their health information within 4 business days, and this can be on CD, it can be on a memory stick, it can be on paper, but they need to be able to have electronic access. And then finally, use certified EHR technology to identify patient-specific educational resources and provide those resources to the patient if appropriate. Next slide. So I think the next slide is a summary slide. Next slide. Okay, so the core measures you see on slide 31 here, these are all the ones that I alluded to earlier. They're all required. Next slide. And then finally, the menu set where you need to meet 5 of the 10 of these. Next slide. So the final rule was released in July, and most of the EHR companies have been working frantically to make sure that their software meets these criteria. And now the Drummond Group and CCHIT will be certifying each of the EHR companies to make sure that they meet these meaningful use criteria. So this is all in progress right now. Those of you who are already using EHRs will probably be receiving upgrades, patches. There will be software adjustments to those of you who are already using EHRs, but certainly those of you who have not yet, as yet, begun using EHR technology should purchase, only purchase software that's going to be able to get these items in a certified fashion. The final piece that we'll be talking about will be the clinical quality measures. We'll get to those. Next slide. This next slide is important because you don't need to get everything from one EHR company. You can mix and match. You certainly can follow a best-of-breed policy, bringing in a practice management system from one vendor, bringing in your EHR from another. If the EHR you have does not currently have e-prescribing, you can purchase a freestanding e-prescribing module. The ONC does not say that one system has to provide all of these services to you. You can combine them in a modular fashion. But in the end, you have to meet all the criteria with the various pieces that you're able to put together there. Certainly it's easier to go with a complete EHR that provides you everything you need under one structure, but not everybody has that ability. Next slide. Bottom line, you have to be using certified EHR technology. If you have one already, is it certified? What plans does your vendor have to become certified? When will they be certified? If you have not migrated to an EHR, then only choose from a company that is going to be currently certified. Next slide. What Joel alluded to earlier is also very, very important. The ONC, in their final rule, clearly state that they want us all working together as a team. If you spend much of your time, a significant portion of your time, in a hospital, make sure you do everything you can to be part of that process to make sure your hospital is certified as well. Because you may do everything correctly, and as you heard earlier, you may have 40% of all your services in your office, and you've got it all battened down and you're certified, but you spend some time at a ASC that's not certified, and spend, God forbid, a large portion of your time at a hospital that's not certified, you would not be eligible. Next slide. Okay, so that's the first pillar, the certified EHR. The second pillar is health information exchange. And these are measures that correspond to the objectives that were set out in the certified EHR, and they're designed to provide digital data to patients, public health agencies, and other professionals that are providing care for your patients. Next slide. Some of the measures will require numerators and denominators. Some measures are yes and no. Some measures will require what we call attestation. We're going to address all of these in a few minutes here. Next slide. This table gives you a few examples of what we're talking about as far as numerators and denominators. So for CPOE, this applies both in the office as well as at your hospitals. More than 30% of all unique patients with at least one medication in their medication list seen by you must be, these prescriptions must be provided using CPOE. On the second bullet, more than 40% of all permissible prescriptions must be provided with EHR technology. The third one is critical, and this is what I alluded to earlier with respect to faxes. Many of us receive faxed lab data, CBCs, CMPs, from various labs. This is no longer acceptable. In stage 1, 40% of all that clinical lab data must be incorporated as structured data. So your CBC is a hemoglobin, hematocrit, MCV, MCH, MCHC. Each of these individual fields needs to be entered into your EHR. You're not going to be able to do that in a cumbersome fashion where there is human input. This has to be electronically interchanged. And then finally, the clinical summaries that are provided to the patients, at least 50% have to be provided. It's actually within at the end of 3 business days or within 4 days. Next slide. The third pillar, and this is going to be our focus going in the future. Once the structure is all set up, our work over the next few years will be predominantly with quality measures reporting. Next slide. These quality measures, by definition, are measures of process, experience, and/or outcomes of patient care that represent observations or treatment that relate to one or more quality aims for healthcare, such as effective, safe, efficient, patient-centered, equitable, and timely care. Next slide. In developing these measures, strong consideration has been given to those that were generated by the National Quality Forum. They do state that they give preference to this, but they also do leave it open that they do not need to use NQF-endorsed measures. What was required for stage 1 was that any quality measure that was to be utilized for meaningful use had to already be stated in the Federal Register. So the ones that you're going to see in the lists for stage 1 correspond very closely to what's been used in the PQRI program. There will be many more coming in the future, but those that were already established, already published in the Federal Register, already receiving NQF endorsement, largely correspond to those that you're familiar with in the PQRI program. Next slide. there are core quality measures, and then there are specialty-based quality measures. These three quality measures, all NQF endorsed, are those that are required by everyone in stage 1. So these should be attainable. Number 1 being preventative care and screening, inquiring about tobacco use. We all do that when we take histories on patients, blood pressure measurement. And then the third one, which may be somewhat difficult for some people, drugs to be avoided in the elderly. This will require a sensitivity testing in your EHR as to where you want to set the level of sensitivity for this. Next slide. For GI, these are the measures that we will have to comply with, and they are all PQRI measures. You should be familiar with them if you've done anything to try to participate in the PQRI process, and it should be noted also that you can still participate in the PQRI process and receive PQRI funding in addition to your meaningful use funding. So hepatitis C and colonoscopy surveillance for patients with adenomatous polyps are the two major categories that drive the GI quality measures. Next slide. Now, how do we, we're going to spend a little bit of time here now on how we report this, how this gets to CMS. We need to submit summary quality measures to CMS, and we need to submit our core measures, our menu set, but unfortunately, CMS clearly states that they will not be ready to accept these electronically in 2011. So what they are intending to do is to establish a secure web portal for reporting. And for stage 1 in 2011, we will need to log on to that website and answer a litany of inquiries that allow us to attest to the fact that we are complying with those quality measures. All providers will be required to electronically submit this data under stages 2 and 3. But in stage 1, attestation will be the way that CMS will prefer to accept this information, because they're not capable at this point of accepting it electronically. Next slide. So you will need to register in that secure website, and then there are several potential routes to report the quality information on that website. Use the CMS portal, or submit the required clinical measures using your EHR, or through registries. In stage 1, though, it appears this will be purely on the basis of attestation. Next slide. The reporting period for meaningful use is something you need to know about. In stage 1, they're giving us all a little break. All we need to be compliant for in stage 1 is a continuous 90-day period within that 2011 payment year. So let's say you're in the process of implementing an EHR now, or about ready to buy one. That doesn't mean you can't receive incentive payments in 2011. As long as you are live and able to submit quality metrics for a 90-day period within 2011, you will still be able to collect your 2011 incentive payment. So it's only applicable to 2011, though. After that, the entire calendar year will be required. You will need to be compliant for the entire 12 months of the year. But 2011, we do get a little break. Next slide. So consider your personal circumstances. Are you an eligible professional? If you are a hospitalist for GI, but let's say you still do outpatient ERCPs, outpatient colonoscopies, you still may be able to be eligible. But 90% of your services, if more than 90% of your services are performed on patients who are in an inpatient setting, then you are not. But many hospitalists today will provide inpatient services, but also will perform outpatient procedures that need to be done at the hospital. So if those add up to more than 10% of your services, you may still be eligible. Do you have certified EHR technology available at the locations where you practice? And again, I do believe it's important for us to make sure that we do everything we can to facilitate our hospitals becoming certified as well, since so many of us in GI still spend a significant portion of our time at hospitals. Can you comply with meaningful use if you practice in multiple settings? That 50% rule is something you need to meet. Which of any of the objections are you maybe exempt from? Which quality measures will you report? CMS estimates it will take 8 to 10 hours per physician to complete the reporting by attestation on the website. So this is a major investment of your time. Your final question, the most important one, is your practice ready for this, and what do you have to do to get ready? Next slide. How long will it take? This is a typical Gantt chart of the process that it takes and the steps that you need to go through. You need to select your vendor. That means going through demonstrations, and this takes time. You have a legal phase. You're going to sign documents. I've never seen one of these companies provide me a legal document that's not based in their best interest rather than mine. A lot of things are negotiable there, but that takes time. There's a financing phase. Then your implementation phase. You have to set your system up. Your data elements have to be worked out. Your hardware. Are you going to host it in-house? Are you going to use an ASP model? What is your network situation? All of these things impact your process. And if you look at this slide, you've got an 8-month period here, which I would consider a minimum in what it takes to get one going. So if you haven't started, you have to get started right away. Next slide. So finally, if you haven't purchased, start as soon as you can. Look for a certified EHR. Modular pieces are definitely acceptable, but you have to have a whole system in the end. If you're in your early phases, the vendors are all trying to get certified at this point, and so even if you've purchased and you're already implemented, you may have some further adjustments. And then finally, you need to do your gap analysis if you're already up and running, and make sure that you've got all your I's dotted and your T's crossed. Next slide. I'm going to turn this back over to Joel right now, and he will close.
Thank you, Larry. Certainly, on some hands, it might be a daunting subject, but I think you've done a marvelous job of helping to parse out what are the key issues for a gastroenterology practice, and certainly put this into a meaningful manner. Well, what's the milestone timeline that we need to be aware of? Let's kind of take a few moments to look at this. In the fall of this year, the first certified EHR technologies will become listed on the ONC website. In January of next year, registration for the incentive program begins. Also, if you elect to go down the Medicaid route, states may launch their programs if they so choose. By April of next year, attestation for the Medicare EHR incentive program begins, and in May, incentive programs will begin. By mid-November of 2011, in fact, the end of November, forgive me, will be the last time for eligible hospitals and critical access hospitals to register and to attest in order to receive their incentive payments. In February of 2012, that's a leap year, so it's February the 29th. That'll be the last day for eligible providers to register and attest to receive their incentive payments for the calendar year of 2011. The Medicare payment adjustments, as we've mentioned, will begin in 2015 for those who have not become meaningful users of EHR technology. And then 2021 will become the last year to receive Medicaid EHR incentive payments. 2016 will be the last year to receive a Medicare EHR incentive payment. Next slide, please. You know, there are lots of resources. This is one of those times when you can say, really with a smile on your face, there are folks in the government and they really are there to help. The two best resources, Medicare's website at cms.gov/EHR incentive programs, and then also the Health IT site, healthit.hhs.gov. Both of these have a wealth of information and are frequently updated as stuff comes out of Washington. Next slide, please. Questions that have been asked, we've already received one question by email, was why do we have registries and how can they help you to meet meaningful use? Some of the key issues regarding this obviously relate to the measures within the meaningful use standpoint. The Digestive Health Outcomes Registry, which was launched in May, currently is the largest outcomes registry devoted to GI conditions. Initially is focusing on management of inflammatory bowel disease and strategies for colorectal cancer prevention. And it is a CMS certified portal for the PQRI hepatitis measures incentive funds. Next slide, please. Registries, as have been mentioned beforehand, provide participants with tools that would fit into the practice workflow, benchmarking, the ability to demonstrate resource efficiency, the ability to manage patient populations in this coming era of value-based healthcare and accountable care, integration with EHR systems, and has been mentioned previously, the AGA and GMED are well down the path of making sure that the GMED EHR system allows direct entry into the registry, and there are others coming down the pathway as well. And then, of course, participating in a registry is the means for participating in health plan and Medicare incentive programs as a practice of distinction. You will be hearing a lot more about this in the months to come, but it is also very apparent from an announcement several weeks ago's time by several major health plans, including United, Anthem, WellPoint, Aetna, Highmark, and others, that they are going fully down the pathway of incenting physician practices who have electronic health record systems and who report measures into a registry which captures the data upon which the health plans themselves are being incented, whether it is on the commercial population for HEDIS measures, in the Medicare fee-for-service population, PQRI measures, or in the Medicare Advantage population, the CMS STAR measures. And those are very critical things that will drive networks and registries and reimbursement during this decade. Next slide, and I think I'm turning this back over to Debbie. Any questions? Next slide for you, Debbie.
Yes, I'm picking up here. Thank you. And thank you, Joel and Larry, for really a very informative presentation on very complicated rules and regulations and work that all of our practices need to do. We do have some really great questions. Just one little housekeeping one that has come in regarding the handouts for the presentation. Yes, within a week, the presentation handouts will be available on the gastro.org website, as will a video of the presentation with audio. Also, the coupons that are available for those who registered for today for the EMR field guide for gastroenterology and selecting an EMR for a GI practice. Those coupons will be emailed to you after the webinar. So just some housekeeping questions that came in. Now the more technical questions, this one I will direct to Dr. Brill. How will the 90% of allowable services be determined? Will it be from years prior to implementation of the EHR or post-implementation? How is that going to, what factors will be taken into consideration to determine that 90%?
Debbie, you've stumped me. I will answer it by saying that I'll be happy. I think we'll be happy to go back and research what CMS has recently posted on that to clarify the exact answer as to when the 90% starts. Larry, do you have an? I don't think we have specific.
I think according to the language, the way it's written, that would be for your, let's say, your 90-day period in 2011. It's concurrent. It's current. So
right.
For those 90 days, if more than 90% of your services are provided on patients who on their encounter are in an inpatient setting, then you are not eligible. And so I think that's the way CMS is calculating this. Because every patient, every service you provide has a location. And if that location is an inpatient location and it counts up more than 90% of your services, then you're not eligible.
So you really have to look carefully when you start your time and take into consideration vacation time, other type of protected time and the like to make sure that you don't fall afoul of that window, correct?
Yeah, later on you're going to have a whole year. But in 2011, since it's just a 90-day period, and I've advised some physicians, just take a look. I mean, if you're the hospitalist, your partners are probably sending you their outpatient ERCPs to be done at the hospital too. So those are, even though they're done at the hospital, they're done in an outpatient setting. So that would help you stay under that 90%.
Okay, thank you. The next question is sort of almost a follow-up to that, which is on the 50% in terms of the location of in the office setting versus where there are certified EHRs versus not. Is that based on the time or the amount billed? This particular person who wrote in says, my physician scopes all morning in the ASC and then does clinic in the afternoon. So they're wondering sort of how do they calculate that?
Debbie, it's the number of encounters as far as I interpret this. So actually, if the doctor is seeing 12 patients in the office in the afternoon and does 8 procedures in the morning, it's not a question of the time. It's a question of the services provided. So he would have 12 services provided in a certified venue and 8 services provided in a non-certified venue, which would satisfy over 50%.
And just to follow up on that, Medicare has no ability to determine how much time you spend on each encounter. They can only aggregate how many encounters you provide within that calendar day.
Great. Thank you. Our physicians perform outpatient procedures at a hospital 4 days per week and are in the office 1 day per week. They have access through the internet at the hospital to our EHR system. Will this qualify, or does the hospital have to have their own system?
The hospital's system needs to be certified. It's setting.
The other issue that you have to consider is, are they doing procedures that are outpatient procedures? But again, as Joel alluded to, I mean, if 50% of the services or more are provided in a facility that doesn't have a certified EHR, they're in trouble.
Yeah. So I think the key follow-on to that one is that it's where you provide the services. Does that setting have the certified EHR or not?
Right. I've taken the approach in one of our hospitals where I'm the physician chairman of their CPOE committee to make sure we get them on board. We need to help. We need to look upon ourselves as all part of a common provider system, and it's in our best interest to have those hospitals be certified.
Okay. Just looking through here. As an ASC that is physician-owned, will our ASC be certified? And if I remember correctly, ASCs will not be certified or are not a part of this equation. Is that correct?
That's correct.
I'll start with that. Under the rules, ASCs were not identified as a setting for certified EHR technology.
Okay, thank you. That clarification. If a physician doesn't qualify due to the 50% rule, then are they going to be subject to reimbursement reductions in the future?
Well, the 50% rule, you know, in the short term, we're talking about qualification for EMR incentive payments. The question, though, and I think for those who are either asked that question or looking at that, need to go back and look at that slide, which looks at what happens after the incentive payments run out and whether you meet the, you know, the qualification of providing services or, you know, the 75% of services to Medicare patients. I mean, if you're not providing services to Medicare patients using, you know, certified EHR technology in settings that are, you know, which must be certified to have EHR technology, you're looking at a reduction in your payment structure by the middle of the decade, and that increases year by year into 2017 when you're looking at a 3% per year decrease. And that's a decrease across your board, across all of your Medicare payments. And I'll just take an extra second on this because I think this is a real critical thing that people need to recognize. It's becoming increasingly apparent that Medicare has already put into place an incentive payment structure which will incent physicians, if you add up e-prescribing and EHR incentives and PQRI participation, there's close to an 8 to 10% differential in payments between those who participate and those who do not participate by the middle of this decade. And you've got to assume, if you're going to read the tea leaves, that the commercial payers aren't going to be that far behind. Larry, would you add anything else to that?
I think that's eloquently said. The train's gone. You better be on it because they're going to utilize every tool they can to financially incentivize us or disincentivize us to be electronic. It'll be substantial differences.
Okay. Thank you very much. We're at the end of our time now. Thank you again to our speakers and to all of our participants. We appreciate your taking the time to join us today. For more information about the CMS Electronic Health Record Incentive Program, you can go to the websites that were listed on the slides, but I'll give that to you again. The incentive program can be accessed at www.cms.gov/EHR incentive programs. And if you're interested in the AGA registry or want more information regarding that, you can go to www.agaregistry.org. We thank you all for your participation. We had a number of questions that were not addressed, and again, we will also summarize those and post those along with the slides and audio within a week. Thank you all very much. Have a good afternoon.